Good evening and good day, everyone. Welcome to HKL RT series. I am Dr. Ananda Kumar Balakrishnan, clinical oncologist in Hospital Kuala Lumpur. And today I'll be presenting on radiation in regards to hematological malignancy. So I've divided this presentation into few parts so it's easier to stream through. The first part, I'll be talking on Hodgkin's and non-Hodgkin lymphoma. Subsequently, we'll be talking on primary CNS lymphoma, another presentation on NKT cell lymphoma, and finally, another presentation on plasmacytoma and also multiple myeloma. So let's get started with our first presentation. So I would like to talk about the evolution of lymphoma treatment. Before the 1940s, the mainstream of treatment for lymphoma was mainly surgery and radiation. And during the Second World War, in the 1940s, discovery of the nitrogen mustard became a game changer, where it became the first successful systemic therapy. Subsequently, in the 1960s, multiple drug regimens were developed, such as MOPP and AVVD regimes. In the 1990s, developmental of monoclonal antibody became a major game changer in terms of non-Hodgkin lymphoma at the time, specifically DLBCL. In the 2010s, checkpoint inhibitors became implemented into treatment regimes such as nivolumab and pembrolizumab. And now we are looking into CAR T-cell therapy and bispecific T-cell engagers. In Malaysia at the moment, CAR T-cell therapy is available in clinical trial setting. We don't really use that widespreadly in the hematological fraternity. I'm not really sure about the bispecific T-cell engagers as of now. Moving forward, I'll be talking a bit about radiotherapy evolution in lymphoma. So in the earlier years, it was total nodal irradiation, as you can see in the first picture to your left, whereby the darker areas were all irradiated. So it's from the cervical region to the axilla, mediastinum, para-aortic, all the way down to the inguinal. Subsequently, they reduced the dose volumes to extended field radiotherapy, whereby you have a mini mantle where you involve bilateral cervical, bilateral axilla, and mediastinum, and another supplementary Y inverted Y field where you get the para-aortic and also bilateral inguinal. Further down the line, the radiation field got smaller and smaller by first being involved field radiotherapy. So treatment sites are just limited to, for example, axilla and SCF, or mediastinum and SCF, para-aortic, or inguinal. And now we are talking about, we are looking into involved site RT and involved nodal radiotherapy. So ISRT and INRT is not, it's almost similar, but ISRT is slightly larger. We'll talk about that further later in the presentation. So the first topic being Hodgkin lymphoma. So Hodgkin lymphoma, previously known as Hodgkin disease, was discovered by Dr. Thomas Hodgkin in the 1832. It arises from B-cell lymphocytes, and the presence of red Steinberg cell was a diagnostic criteria. So Hodgkin lymphoma can be further divided into two main groups. The first group being classical Hodgkin lymphoma, and the second group is nodular lymphocyte predominant Hodgkin lymphoma. Classical Hodgkin lymphoma can be divided into four subtypes. The first subtype is nodular sclerosis, the most common subtype, up to 70%. The demographic is mostly common in young and teenage age, female more than males, and the presence of lacuna red Steinberg cell. Prognosis is quite good in this subgroup. The second is mixed cellularity, 20 to 25%, mostly seen in RVD patients and late adults. Male predominates female, and it's commonly EBV associated with good prognosis. Lymphocyte reach is about 5%, predominantly in male and also late adults or elderly. Contains few red Steinberg cell in histology with excellent prognosis. And the final subtype of classical Hodgkin lymphoma is lymphocyte depleted, which is quite rare, commonly seen in elderly and immunocompromised patients, and is the most aggressive subtype. Many red Steinberg cells with few background lymphocyte. Prognosis is quite poor. So the other type of Hodgkin lymphoma, the NLPHL, it's an indolent rare disease, predominantly in male, with a bimodal peak in childhood and also 30s. Good prognosis, but it also has a 3 to 17% transformation risk into a more aggressive DLBCL or T cell lymphoma. Staging for lymphoma is using the modified Ann Arbor staging system. So we can divide the disease into two, limited and advanced stages, or early and advanced. So for stage one, involvement of one node or a group of adjacent nodes. For stage 1E is single extranodal lesion without a nodal involvement. For stage 2 is two or more nodal group on the same side of the diaphragm. So for example, if it's the cervical lymphadenopathy with mediastinal involvement, or cervical lymphadenopathy with axillary lymph node involvement, so it's considered as stage 2. Stage 1 and stage 2 by nodal extent and with limited contiguous or direct infiltration into extranodal organs or structures is considered as stage 1 or 2E. And stage 2 bulky is with the bulky disease. So bulky can be defined with a few different criteria. Some take 7.5, some take up to about 10 centimeter. For the advanced stage, for stage 3 we have nodes or involvement of the disease in both sides of the diaphragm, or nodes above the diaphragm with spleen involvement. For stage 4 is additional non-contiguous extralymphatic involvement, for example, bone marrow. Next, we're going to talk about unfavorable risk factor for early stage Hodgkin lymphoma. As you can see on the slide, there are few different criteria. We have the German Hodgkin Study Group, followed by EORTC, the European Organization, and also NCCN. So it's very important to always clarify with your hematologist or your referring hematologist on which criteria they refer to help you decide on which either favorable or non-favorable early stage do the patient fall into. So the role of PET-CT in lymphoma is a very vital imaging. It determines the initial staging, it determines the response towards systemic therapy, and it is also used as reassessment post other modalities like immunotherapy or radiotherapy as well. So it's a major game changer in the treatment of lymphoma. So usually PET-CT is described with SUV or the FDG uptake. But in lymphoma, we use PET-CT response assessment with Dewey's criteria. So the Dewey's criteria is actually created to determine whether it's disease or not disease, because we are talking about areas where there is lymphatic involvement. So the normal lymphatic tissue, the reticular endothelial system do have their baseline or background SUV uptake. So how do we differentiate whether it's a physiological uptake of the node or if it's an inflammation compared to a disease itself? That's why Dewey score was created. So a PET negative score is actually Dewey score 1 to 3, whereby Dewey score 1 there's no uptake at all. Dewey score 2 is uptake that is less than the mediastinum physiological uptake of that patient. Dewey score 3 is uptake of the the uptake of the lesion is actually more than the mediastinum, but it's actually less than the liver of that patient. Dewey score 4 is when the uptake is moderately higher than the liver uptake, and Dewey score 5 is when the uptake is markedly higher than the liver, or is it a new lesion? But new lesion also sometimes reported as X or some other uptake due to inflammation that's not related to lymphoma can be reported as X as well. So now we're going to talk about a few landmark trials in Hodgkin lymphoma. The first being the German Hodgkin study group HD7 trial, whereby this trial enrolled Hodgkin lymphoma favorable disease patients for about 650 patients of stage 1A to stage 2B, and they divided them into two arms, where arm A received 30 degrees of extended field radiotherapy plus 10 degrees of boost to the involved field, and arm B 2 cycles of ABVD followed by 30 degrees of extended field radiotherapy plus 10-degree boost to the involved field. So there was no difference in the complete response rate or the 7-year overall survival. However, the freedom from treatment failure is different, and the group with the combined modality became standard of care and superior. Next is followed by the HD10. The HD10 trial included 1,300 patients with early-stage Hodgkin lymphoma, favorable disease, and these patients were divided into 4 treatment arms. The first arm received 4 cycles of ABVD and 30 degrees of radiotherapy. The second arm received 4 cycles of ABVD and 20 degrees of radiotherapy. Third arm, 2 cycles of ABVD, 30 degrees of radiotherapy, and the fourth arm received 2 cycles of ABVD with 20 degrees of radiotherapy. So there was no difference in the freedom from treatment failure in all 4 arms, either comparison with chemotherapy or the radiotherapy doses. But this is a non-inferiority trial, and the 2 cycles of ABVD with 20 degrees of involved field radiotherapy was non-inferior and less toxic. Hence, it became the treatment option for early stage favorable disease Hodgkin lymphoma today. The next trial that I'm going to talk about or share today is the HD16 trial. This trial shows the incorporation of PET-CT into early stage favorable disease. The HD16 trial included 1,150 patients that were divided into 2 arms. The first arm being the standard treatment at that point of time, whereby 2 cycles of EBVD was given, followed by PET scan, and regardless of the PET result, patient received 20 degrees involved field radiotherapy. The second arm was the experimental arm, whereby the patient received 2 cycles of ABVD followed by PET scan. And based on the PET scan, the treatment was differed. So the first arm received no radiotherapy if the Deauville score in the PET scan was 1 or 2. And if it's PET positive, then they receive 20 degrees of involved field radiotherapy. So this trial concluded 2 things. If there's PET positivity after 2 cycles of ABVD, there's higher risk of treatment failure. And PET negative patients, RT can be safely omitted if it's a combined modality treatment. Next, we're going to talk about HD11, which was a pre-PET trial in unfavorable early stage Hodgkin lymphoma. The HD11 trial, which is a pre-PET PET-CT era trial, it included stage 1 and stage 2 unfavorable Hodgkin lymphoma cases. So these patients were divided into 2 arms. The first arm being receiving 4 cycles of ABVD, and the second arm receiving 4 cycles of baseline Birkhoff. The ABVD arm is then further divided into 2, where patients received 30 degrees of involved field radiotherapy, and another group receives about 20 degrees of involved field radiotherapy, and the same was done to the Birkhoff arm as well. So they compared 4 arms in total. The treatment point is to see comparison between baseline Birkhoff and ABVD, and the comparison between the radiotherapy doses of 30 degrees and 20 degrees involved field radiotherapy in unfavorable Hodgkin lymphoma early disease. So the worst outcome was actually documented with the arm of 4 cycles of ABVD and 20 degrees of involved field RT. If you can see here the yellow line, so that actually showed the worst arm, and 4 cycles of ABVD and 30 degrees of radiotherapy, involved field radiotherapy, became the standard of care because it's non-inferior compared to all the other 3 arms. And the Bierkop arm, as we all predicted, showed more hematological toxicity. Hence, ABVD 4 cycles and 30 degrees of radiotherapy consolidation became a standard of care. The next trial that we're going to look into is HD14. So the HD14 included patients of early stage unfavorable Hodgkin lymphoma, and they were divided into 2 groups. The first group received ABVD 4 cycles, followed by radiotherapy 30 degrees. The second group received 2 cycles of escalated Bierkop, followed by 2 cycles of ABVD and radiotherapies of 30 degrees. So we noted that in the escalated Bierkop arm, it showed improved progression-free survival by 7.2%, similar or as overall survival between the 2 arms, but however, as we all know, increased hematological toxicity up to 80% as compared to 24% in the ABVD arm. So this is favorable towards the ABVD. The next trial that we're going to look into is HD17, which is a PET-guided omission of radiotherapy in early stage unfavorable Hodgkin lymphoma. So in this trial, patients of early stage unfavorable Hodgkin cell lymphoma were divided into 2 groups. The first group received 2 cycles of Bierkop, followed by 2 cycles of ABVD and consolidation radiotherapy of 30 degrees involved field radiotherapy. The second group received 2 cycles of Bierkop and 2 cycles of ABVD, and then there was a PET assessment. If there is PET negative, post 4 cycles of chemotherapy, the patient will put in observation arm, and if it is PET positive, patients were given 30 degrees of involved field radiotherapy. From this trial, we can conclude that radiotherapy can be omitted with PET negative post intensified chemotherapy backbone. Hence, the importance of PET scan in this type of malignancy is further enhanced. The RAD-HL trial or the RATTLE trial included stage 2B to stage 4 advanced Hodgkin lymphoma. Radiotherapy was omitted in patients who had PET negative after the systemic therapy, but this trial was actually not powered to compare effects of omitting radiotherapy, so hence it's not really referred to. Next, we have the HD12 and the HD15. Both of these trials actually showed that radiotherapy for residual disease post-systemic therapy improves progression-free survival. So it's very important to discuss with your hematologist on what guidelines do they adhere to. Do they adhere to the European ESMO guideline or EORTC guidelines or NCCN guidelines for the matter, to determine or correlate with their treatment as well. So if you look at the ESMO guidelines, stage 1, stage 2 classical Hodgkin lymphoma, for favorable early disease is 2 cycles of ABVD, followed by involved site radiotherapy ISRT 20 degrees. And for the unfavorable group, systemic therapy followed by ISRT of 30 degrees. So, treatment for the advanced stage Hodgkin lymphoma, stage 3 and stage 4, may be a bit different if you look into ESMO as compared to NCCN guidelines. So for NCCN guidelines, there are some arms where they suggest that patients started with 2 cycles of Bierkop or BICAD, and then followed by PET assessment. And if the PET assessment is positive, the patient is further continued with Bierkop or BICAD, and then followed by PET. Or if it's PET negative, there's an option of de-escalating it, the patient into ABVD. But if you look at the ESMO guidelines, a bit different. Radiotherapy consolidation is always given in stage 3B, stage 3 and also stage 4 Hodgkin lymphoma. Now let's go into the contouring aspect of Hodgkin lymphoma. So when we talk about contouring, yes, we definitely have our GTV, CTV, and PTV. So we look into each one. So GTV is the residual tumor or gross tumor that you see during simulation. CTV is the initial extent of the disease, superior inferiorly, excluding all the uninvolved OAR or organ at risk based on your clinical judgment. And separate nodule volumes need to be contoured. For example, you have a huge tumor in the level 1B or level 2, but there was also another bulky disease somewhere in the supraclavicular region. So if these lesions uh, were to be treated and they are less than 5 centimeter, you can encompass them within the same CTV. But if they are more than 5 centimeter apart, the GTV itself, then you have to contour them as a separate CTV. ITV is recommended for lymphomas in the upper abdomen and also in the chest. This is because of movement due to respiratory. We need to grow another 1.5 to 2 cm superior inferiorly from our CTV for ITV. The PTV is institutional, but I generally grow 0.5 centimeter all around. So now we come to the topic about involved site radiotherapy versus involved node radiotherapy. So for involved site radiotherapy, that's what we commonly generally practice, I think in most centers in Malaysia as well. Because it's due to the suboptimal imaging and also clinical information. So when we look at involved node, optimal chemotherapy imaging is very ideal. So the treatment imaging, pre-chemotherapy, interim scan, and the simulation ideally needs to be within the same position. So for example, you're treating the axilla, the location of the area where you're treating for an auxiliary patient in a CT simulation where your hands will actually be up as compared to a diagnostic CT where the hands would ideally be down, could be down by the side or even resting upwards, would change the area where you're going to treat. So hence, involved node radiotherapy is not commonly practiced because due to the suboptimal imaging that we get from the very beginning. When you compare to the size of the CTV, involved site radiotherapy has a larger CTV. Involved node radiotherapy actually has a smaller CTV with smaller expansions around the gross tumor. So modality or technique of treatment in lymphoma is very, very crucial. So selection of treatment technique is a clinical judgment. So what helps you decide what kind of technique that you're going to use is mainly patient's age, gender, location of the tumor, the dose of the radiotherapy that you're going to use, and how much of splashing of low dose or even high dose volume for that matter. So for example, if we take this first picture, is actually showing a 3D technique for a mediastinal lymphoma using an APPA technique. So the area that is red is ideally your 95%. The green is showing the beam entry, which is your 50%, and this is the low dose, which is less than 5%. On the right, this is the same patient being treated using VMAT technique, ARC technique, whereby you can see the dose is much more conformed to the area of your PTV, the red color, and the green is your beam entry, and the low dose splash is lower as compared to 3D because it's much more conformal. But when you look into the higher dose, which is the red one, you are treating areas, especially the breast. So this is a female patient with a breast. So you're exposing this patient's breast tissue, certain amount of the volume up to about 40 grays. if you're treating this patient to 40 degrees, as compared to here where the area of the rate is actually avoiding the breast to a certain extent. So the volume of the irradiated breast is much more lower, and it's more conformal. So for patients who are young, with mediastinal radiotherapy, sometimes we tend to choose 3D technique consolidation. The reason being is we do not want a lot of splashes to all the other OARs um, uh, uh, around the treatment area. But when you're going or pushing the dose a bit higher, other things can be a limiting factor. So for example, if you're treating 40 degrees with a 3D technique, but your lung and your heart becomes your limiting factor for approval of your plan at that time also. So you have to look into all those things when you're approving your plan and choosing your modality. Now let's look into radiotherapy in relapsed and refractory Hodgkin lymphoma. So there's a very nice paper by Ilrock regarding this topic that you can read further into, and I have used reference from that paper as well for my slide. Salvage radiotherapy where complete response has been achieved after the salvage chemotherapy, whereby the Deauville score and the PET-CT post chemotherapy is 1 to 2. So the adequate timing for radiotherapy is actually immediately prior to the stem cell transplant. So the dose actually differs throughout. So if we look at one, it's actually if you achieve complete response, Deauville's 1 and Deauville's 2, the dose is about 30 grays. If there is complete metabolic response, but the residual disease in the PET is actually more than 2.5 centimeter, it's recommended to escalate up to 36 grays if it is safe. So you have to look into your OERs. If the Deauville score is 3 and the area that the Deauville score 3 is a critical location whereby the tumor was active previously, then it's safe. It is recommended to escalate to 36 grays if it is safe. If the patient was previously radiated before the current chemotherapy, it is always important to look into the OAR doses before deciding the current radiotherapy dose. If it is not safe to achieve the uh, optimal or maximum OAR tolerance, it is always important to discuss back with your hematologist saying that radiotherapy is not possible. If the patient has actually has a disseminated disease currently, and it can be encompassed into a mini mantle or inverted Y extended field radiotherapy, then a dose of 30 to 36 grays to all the involved site can be considered with regards taking into account the toxicity profile. So the volume of our contouring, ideally, if you can encompass all the involved disease site into the irradiated field, it will be ideal. But if toxicity is the main concern or the tumor was humongous before, and trying to push the dose to 36 is giving you a lot of limitation in terms of your OAR, then consideration of only treating the refractory areas should be taken into account. Some do suggest treating the higher dose at the areas of the refractory, and you can give a lower dose to the areas of the previously involved areas, sort of like an SIB technique. So radiotherapy in partial response after salvage chemotherapy, whereby the PET scan shows Deauville's 4. So the timing of the radiotherapy is before the stem cell transplant. Recommended dose is about 30 to 36 gray, and to the area of complete response, and boost the partial response area to 36 to 40 grays. But similar to previous scenarios whereby you have to take into account your OAR toxicities as well. Next, we are looking into salvage radiotherapy for patients who have persistent refractory disease or progression of disease, whereby the PET scan is actually showing Dewey's 5. So for these patients, we need to discuss in the MDTs whether there is an alternative salvage chemotherapy or biological agents like brentuximab or PD-L1 checkpoint inhibitors that the patient can consider, or we are strongly pushing towards stem cell transplant. So if they are still insisting for stem cell transplant, then a higher dose of radiation need to be considered, whereby the area of the progressive tumor should be irradiated up to about 40 to 45 grays, and similar consideration of SIB to the other areas of a lower dose volume. So for patients with early stage Hodgkin lymphoma who relapsed without radiotherapy being given in the first line, so for these patients, we need to see whether they are planned for stem cell transplant or they're not planned for stem cell transplant. So if they're not planned for stem cell transplant, after the salvage chemotherapy, the involved site radiotherapy needs to be started 2 to 4 weeks after the chemotherapy is completed. So dose varies in terms of CR and PR. So for CR, you give up to 30 to 36 grays, and in PR, you try to push the dose up to 40 grays. So as we have seen previously as well, so they do recommend to give 30 to 36 to 40 grays to the area of the PR, and the other involved areas to be irradiated up to about 30 grays, so SIB technique. So there are some instances where we get patients referred to us in relapsed refractory Hodgkin lymphoma, but they're referred to us post stem cell transplant. So they've received salvage, conditioning, and stem cell transplant, and then referred to us for radiotherapy. So for these patients, we need to wait for their stem cell transplant toxicities to subside, and ideally start the treatment 4 to 12 weeks after the stem cell transplant. The dose recommendation is similar to previous scenarios. So now we look into the scenario where the patient is not transplant eligible after the relapse or refractory. So if the patient actually achieved complete response to the salvage therapy that is actually given, so the area of the relapse could be irradiated up to 30 to 36 grays. If only partial response was achieved, as seen previously, we'll push the dose up to about 40 grays. And if there is no salvage therapy planned for the patient due to fitness or comorbidities or anything, then we need to discuss the goal, whether it's still palliative or curative, to decide the dose and how big of a volume that you're going to irradiate. A bit on NLPHL. So stage 1A and stage 2A with no bulky disease is usually ISRT alone. Uh, for stage 1A, stage 2 bulky, stage 1B, stage 3 bulky is usually chemotherapy followed by ISRT plus minus rituximab. There are also other chemotherapy options that's available and given in this type of lymphoma, such as ABVD, CHOP, etc. So the doses for ISRT in NLPHL is usually 30 to 36 grays. Now we are here to talk on non-Hodgkin lymphomas. So non-Hodgkin lymphomas is divided into two big subgroups, which is the B-cell lymphoma and the T-cell lymphoma. So in the B-cell lymphoma itself, you can look at aggressive and indolent types. So the aggressive types are DLBCL, primary mediastinal lymphoma, high-grade B-cell lymphoma, Burkitt lymphoma. Indolent are follicular lymphoma and marked lymphoma. In the T-cell lymphoma, the aggressive types are the NK T-cell lymphoma that I will talk separately in a different presentation, peripheral T-cell lymphoma, and the indolent ones are such as mycosis fungoides. So indication of radiation in DLBCL. So today I will be talking mostly on DLBCL as an aggressive subtype of non-Hodgkin lymphoma. So in early stages, stage 1 and stage 2, bulky disease and non-bulky disease sometimes are irradiated, partial response post chemotherapy or skeletal involvement of the disease. In advanced stages, stage 3 and stage 4, bulky diseases, skeletal involvement, and partial response are irradiated. So for relapse refractory disease, radiotherapy can be given pre-transplant, bridging to systemic therapy, bridging to CAR T-cell therapy, salvage, or even in palliative setting. So as most of you are aware, this is IPI score that is used to prognosticate the LBCL, but as you can see in the screen, there are so many types. So you need to always ask your hematology counterparts which guidelines are they referring to. So I'm going to talk about few landmark trials in DLBCL. The first being SWOG 8736. This is the pre-rituximab era. So this trial included stage 1 and stage 2E. Bulky disease was allowed for stage 1, and trial was divided into two arms. The first arm receiving 3 cycles of CHOP followed by radiotherapy, and the other one receiving 8 cycles of CHOP. So it is a non-inferior trial showing that 3 cycles of CHOP with radiotherapy is equivalent to 8 cycles of CHOP. Hence, this is treatment de-escalation. There are a few other trials as well in the LBCL. So there are a few trials that actually proved the addition of rituximab to CHOP significantly improved the progression-free survival and overall survival in early stage aggressive non-Hodgkin lymphoma. So we have the ECOG-KGB trial, the Dutch Horn trial, Nordic Lymphoma Group trial, MINT, and the JELA study. So the LISA 0203 study showed that radiotherapy can be omitted in patients with favorable low volume disease with metabolic complete response in PET after 4 cycles of R-CHOP. So this also shows the importance of rituximab. At the same time, the PET-CT incorporation into NHL treatments. The SWOG 1001 shows the benefit of radiotherapy in PET-PR post-3 R-CHOP in early stage NHLs. So then we have the RECOVER trial. The first is being RECOVER NOT trial. So this trial concluded that the omission of radiotherapy to bulky and extranodal areas are detrimental in advanced stage DLBCL, whereby it worsens the PFS and the OS. And we have the RECOVER 60, which actually showed radiotherapy to the bulky disease post R-CHOP improved overall survival and progression-free survival. So now let's look at some contouring guidelines for non-Hodgkin lymphoma. So the GTV is the tumor that we are looking at the treatment planning images. CTV is to include the pre-chemotherapy extent of the disease, superior inferiorly, with expansion about 1.5 to craniocaudal and 1 centimeter expansion axially. And this expansion should exclude air, muscle, bone, and any uninvolved adjacent organs. It might seem a bit big, but when you have ITV, you can actually grow your CTV to 0.5 all around with inclusion of the superior and inferior extent of your pre-chemotherapy disease. And subsequently, the ITV will be grown to 1.5 sub-inf and 1 centimeter or 0.5 centimeter axially. So the PTV for ISRT in NHL differs depending on the area of treatment. So if it's the mediastinum, the PTV is expanded another 1 centimeter axially and 1.5 centimeter craniocaudally from the CTV. If it's a head and neck tumor, then the PTV is expanded 0.5 centimeter from the CTV. And if it is any other sites, for example, if it's in the inguinal region, the PTV is grown 1 centimeter all around the CTV. So let's look at some example. So this is a case of DLBCL of the mediastinum. For the image on the left, or image A, that's the pre-chemotherapy volume, and we can see that there is a tumor adjacent to the SVC. So the tumor is in red and the SVC is in blue. And in picture B, we can see that there is residual tumor, very good response to chemotherapy, uh, at the same site adjacent to the respective vessel. So this is the SVC. So this is how we contour. So the gross tumor is the one in the darker blue, and it is expanded to involve the previous chemotherapy area, and expanded superior inferiorly 1.5, 1 centimeter axially, and cropped off uninvolved area of muscle, bone, trachea, and lung, and subsequently another expansion of 1 centimeter all around with 1.5 superior inferior. So next case, this is another non-Hodgkin lymphoma. So it's a huge tumor in the inguinal region with nuclear fat plain with adjacent vessel fungating through the skin, probably ulcerating outwards as well. So this is the pre-chemo volume, and the post-chemo volume shows smaller residual at the respective area. So for this case, how do we contour? So the residual is contoured with the dark blue, and the CTV is to encompass the area of involved disease pre-chemo, and a 1 centimeter margin all around PTV is given. So dose for consolidative uh, post-PET complete response or previous bulky areas is usually 30 grays and 15 fractions. But if there is partial response, no plan for subsequent treatment, the dose can be pushed up to about 36 grays or 45 grays. And if the patient is actually progressing and not fit, but PET scan does not show disease elsewhere, we can actually go or opt for the higher dose option. A bit on relapse refractory DLBCL. So this is another paper from Europe, the role of radiotherapy in relapse refractory DLBCL. So please have a read on that paper. So we're going to look into few scenarios that was mentioned in the paper. The first being relapse refractory disease after primary chemotherapy with complete metabolic response in the PET. So DUIS 3 to DUIS 4. So dose for pre and post transplant is the same, but if patient is referred pre-transplant, ideally is within 4 weeks before the 4 weeks after the salvage chemotherapy course, and if it is post-transplant, 4 to 12 weeks after the transplantation, depending on the recovery of the patient post-transplant. The second scenario is refractory or relapsed disease after primary chemotherapy with overall reduction of FDG uptake, but the foci is still avid disease with DUILs 4 to 5. So similar, patients could be treated pre-transplant or post-transplant, but the dose would be slightly higher. Can be pushed up to 36 grays in 1.8 or 2 grays per fraction, or even higher if the OER permits up to about 40 to 45 grays. Because it's an active disease, this is not consolidation, so you have to push it higher. So the third scenario is localized refractory disease to the salvage chemotherapy, whereby the PET is definitely DUIS 5. So the dose is the recommended dose is about 40 to 50 grays. The next is relapse refractory DLBCL but transplant ineligible patient. So for this kind of scenarios, we need to discuss with hematology whether this patient is planned for palliative intent. If they have shorter life expectancy, poor ECOG performance status, then you can give a palliative dose. If it is still a curative intent, then we need to push the dose higher, 45 to 50 55 grays. If it is difficult to achieve, then maybe 45 to 55 to the cross disease, and try to encompass the previous involved area up to about 30 to 36 grays. So, OAR constraint or organ at risk constraint in lymphoma is much tighter as compared to those constraints that are given in contact. This is because patients with lymphoma tend to survive much longer as compared to other solid organs. So they do live out to see the long-term sequelae more than other tumors. So hence the reason why the dose constraints are a bit tighter. So if you look into parotid glands, the recommended dose is actually less than 11. In some instances, it's also recommended to push the doses even lower, so lower than 5 grays or lower than 5 grays for all the major salivary gland to avoid uh, high grades of xerostomia. So similar to the submandibular gland. So the mean dose of the oral cavity is also recommended to be similar, lower than 11 grays. So if you look at the mediastinal area, there's a different range of accepted radiotherapy dose constraints given for each organ. For example, the heart, the optimal is less than 5, and for the mean dose, and if necessary, or if you're pushing the doses higher up to about 40 grays, then try to achieve 10 to 18 grays of mean dose. Same goes for the lung, thyroid, and also breast. These are some of the dose constraints for abdomen and other areas. And that's it for now. So I'll conclude my talk for Hodgkin's and aggressive non-Hodgkin lymphoma today here, and see you in the next presentation.